Okay. Yeah, thank you. Yeah, okay. And this is my disclosure, and this is my outlines for today. So what about the definition of hyperuricemia? Actually, there is no universally accepted definition of hyperuricemia if you go to the literature. However, if we will take the physico-chemical definition, it's anything above 7 milligram per deciliter. And if you want to convert it to micromole per liter, roughly you have to multiply with 60. So the commonest question when we have to investigate patient with high uric acid level. Because as you know, we are internists and we have too many patients with high uric acid level, diabetes and psoriasis and hypertensive. Actually, it's like debatable question. However, I believe 8 milligram per deciliter is really a cut point to start to investigate such entity of patient. Why this? Because the solubility of the urate level is above, is until 8 milligram. After 8 milligram per deciliter, all the urate will be deposited in the tissue and the joint kidney. That's why any patient with gouty arthritis, we have to reduce the level bit less than 6 milligram, which is roughly around less than 400. Asymptomatic hyperuricemia, it's really common, and only a third of these patients will turn to gouty arthritis. An average period of asymptomatic hyperuricemia of at least 10 years or more in both males and female prior to the clinical expression of gout. So that's why I think it's really missed entity, and I saw like our colleague in nephrology, they started allopurinol really earlier in this entity of patient because they want to keep their kidney maybe longer. What about gouty arthritis? It's really the commonest inflammatory arthritis worldwide, and it's increasing in prevalence and incidence and burden nowadays, and it is defined as urate crystal deposition inside the joints, and anything above 6.8 milligram per deciliter. And as I mentioned earlier, this is the limit of urate solubility. Since 2012, we have our American College of Rheumatology. They are pushing for a treat-to-target strategy, and we have this strategy in all our diseases, actually, including lupus, rheumatoid, psoriasis. Even in gout, we have such a strategy. However, it frequently remains untreated, patient with gout, and poorly managed, and there is really a big gap, and adherence to the urate-lowering therapy remains poor. What about the epidemiology for gout? If we go to the US, they have it like 3.9 as a prevalence. And in our Saudi Arabia, from our colleague in Riyadh, Prof. Al-Arfaj, he did a study and published it in 2002. And he estimated the prevalence of gout in Saudi Arabia to be 8.4%, which is really not small number. So we have too many patients with gouty arthritis, and maybe higher than this prevalence, but they are missed. What about the ratio for male and female? It's more common in male than female. Why this? Because we believe that gout is a disease of men and postmenopausal women. And because the estrogen play really a protective factor in gouty arthritis. However, this ratio will be equalized after 50. What about the commonest risk factor for hyperuricemia and gout? I think all of you know these factors, including age, sex, ethnicity, genetic obesity, hypertension, hyperlipidemia, diabetes, hypertension, and medications for heart failure and for hypertension. But the classical clinical profile of gouty patient, it's usually we see this entity of patient, middle-aged male, 30 to 60, who is obese, hypertensive, and alcohol consumption. But I believe alcohol consumption not common here as in other country, but the commonest cause for our gouty arthritis is eating too much meat. What about the clinical manifestations of gout? Usually, the patient presents with recurrent flares of inflammatory arthritis, gout flares, and if left not treated, the patient can suffer from chronic arthropathy, and unfortunately, some patients, they will develop tophaceous deposit. And gouty patient can also has uric acid nephrolithiasis and chronic nephropathy. What about the classical clinical stages for gouty arthritis? Usually the patient will start with gout flares, and in between, he will suffer from intercritical gout. And in this period, we have really to fix the urate level, which is really critical period. And if it's left not treated, the patient will suffer from chronic gouty arthritis. What about taking fluid from every patient with gouty arthritis? I think it's not practical because these patients, they are reaching to our clinic after even the gouty flare appeared. That's why I think we can do synovial fluid aspiration only if we have like debate or if there is a possibility of septic arthritis or other diagnosis. However, it's not practical to do synovial fluid aspiration in every clinic, and you know our clinic, they are really, we have really crowded and busy clinic. But we need tool to help us and tell us how we can make the possibility of gouty arthritis higher than the other. This is, I believe in this, score. So if you have anything above 8, the patient will have high probability of gouty arthritis. What about the treatment of gout? It looks funny, you know, when you say patients and some crying are the best drugs for gout. However, you know what happens exactly in gouty arthritis? Oh. Okay, it's not working. Okay. What happens exactly in gouty arthritis? Neutrophil will go inside the joint space and they're trying to get rid of this urate crystal. However, these neutrophils will fail and will go back after 2 to 3 days. That's why the swelling and the cytokines will be subsided. So the patient will have improvement even if you, in his symptoms, even if you don't treat him. However, he will suffer from further attacks. That's why controlling the urate level is really essential. Something to remember, you have to look for the mimicker for gouty arthritis, and the commonest one is septic arthritis. For treatment of gout, you have two things that you have to concentrate on: treating the acute flare and reducing the urate levels. For the acute flares, we have too many medications: NSAID, colchicine, steroid, ACTH. However, you know, choosing between this medication, it can vary from patient to patient, and it depends on the comorbidities and the availability of this medication. Something to remember that colchicine should be given in a golden period, which is in the first 12 hours from the symptoms, and it will be better if it's the first 6 hours from the symptoms. Otherwise, it's considered one of the weakest medication to treat acute flare, and usually we give it as a combo treatment with NSAID or steroid. With regards to the reducing urate level, usually we are giving most of our patients allopurinol unless the patient developed hypersensitivity or refractory cases. We go to the febuxostate. Why this? Because the febuxostate is not formulary in most of the hospitals, and it's super expensive as compared with allopurinol. Something that we have to teach our patient when they are away from from the hospital, they are in the mountain or they are in the desert. Resting the joint and applying ice is really a great treatment for gouty arthritis, because after 3 days, this gouty flare will abate by itself, as I mentioned earlier. What about I know the audience here, most of them student and internal medicine residents, so I will try to simplify it. So if we go to the latest guideline to treat gouty arthritis, this is the latest one, 2020, from our colleague in America, American College of Rheumatology Guidelines for Management of Gout. So for the first line therapy, as I mentioned earlier, you can give low dose of colchicine, NSAID, steroid. You start with oral. If it doesn't work, you can go to the IM, IV, or intra-articular. Then if the patient not responding, you can refer now at this stage to the rheumatology. They can give this patient biological therapy like interleukin-1 inhibitor. What about the commonest indication to start urate-lowering therapy? So any patient with TOFI, radiographic damage, 2 or more attacks per year, chronic kidney disease stage more than 3, any serum uric acid level more than 9, and history of renal stone. Now also I'm pushing for treat to target strategy. I'm seeing like most of our colleagues in primary care, they are putting patient on allopurinol 100 milligram per deciliter, and the patient will stay in this dose for many years, and the uric acid level is still high in 600 and 700. So you have to push the dose. Every 4 weeks you have to titrate the dose of the allopurinol until to reach to your target, which is less than 6 milligram per deciliter if there is no 2,5, and less than 5 milligram per deciliter if there is 2,5. What about checking the gene of Halabi 5801? I think in our country we don't have to do this, but when I was in Canada, they are checking this if they have Asian descent or African American descent. Febuxostate, as I mentioned earlier, it's alternative for allopurinol. However, we have to pay attention if the patient has history of cardiovascular disease or a new cardiovascular event. So we have to switch our patient to allopurinol. Okay. For glucocorticoid, I believe in low dose of glucocorticoid rather than high dose. Why this? Because most of our patients, they are diabetes. So I cannot give them 40 or 30 milligram of a steroid. So I believe of 10 milligram daily for 3 days, then 7.5 milligram for 3 days, then 5 milligram for 3 days, then 2.5 milligram. I'm doing this, for the past 10 years, and all my patients, they are, alhamdulillah, doing great. However, I'm using this dose if the patient is really young, without comorbidities, and he is really limping and he wants to go for work. Of course, the benefit of high dose will go above the low dose. So what about commonest question, shall we give the patient NSAID or steroid? Actually, in terms of efficacy, they are equal. However, there is fewer side effect with the steroid if we compare it with NSAID. Colchicine, we are giving the low dose protocol, which is total of 1.8 milligram the first day, then the subsequent day 0.6 milligram twice daily until the flare abate. And we have to pay attention if the patient has kidney or hepatic impairment, as he need, of course, this patient dose adjustment. What about the prophylaxis? I think we need to give all our patients prophylaxis, especially in the first 3 to 6 months, because they're going to have minor flare. Once the uric acid level is going down, it can cause minor flare, and the patient, he believes that we are giving him really wrong medication, but we have to tell our patient and teach them that you might suffer from small flare, and we will give you colchicine, for example, or a low dose of a steroid of 5 milligram as a prophylactic dose to prevent this minor flare. And the duration, as I mentioned, it's vary from 3 to 6 months. I think you can do, see your patient and the uric acid, and you can say which one is enough for 3 months and which one for 6 months. So at the end, I will say take-home messages. Asymptomatic hyperuricemia always a missed entity, and we have to pay attention. And not all patients with asymptomatic hyperuricemia will turn to clinical gout. And we have really a big gap between gout and the management. So I think we are really having unmet need, and we have to push for treat to target strategy in managing gout. Thank you very much. I hope you did enjoy my lecture. Thank you. Okay.
Thank you very much, Dr. Khawla. Interesting presentation, very common entity. And thank you for taking care of our diabetic patient. So my question is it always we have to wait for a level of 9 in asymptomatic patient to give medication? And my second question, the use of allopurinol during the acute stage.
Okay, thank you, Prof. Al-Alg. He was really my teacher when I was a student. I have to admit this. Okay, for the first question, it's variable, the guideline, but as I mentioned earlier, 8 milligram per deciliter, it's considered really a cut point to start medication and start the investigation. For the second question, since 2015, there was like an article in a New England Journal of Medicine. They said there is no harm to start urate lowering therapy at the time of the acute flare. Welcome.